We are going to start again in 1 minute, so I'll just ask everyone to wrap up their conversations and their food if they're still eating, and we will get started with the next slate of presenters, so in about 1 minute. Thank you. Okay, we're going to get started again, and so I'd encourage the folks out in the hallway to make their way in, and we will get started. So I am not Monique Horn-Miller, our MC. I did not play for the women's national water polo team. I will not move as gracefully through the room with a microphone as she does. Actually, Monique, in order for us to be able to have Monique over these 2 days, we had to make some room for her to go off and speak to another group of people around lunchtime. So she's going to be back, but she asked me to pinch hit for her for this next session, probably through the break. So with that, I'm going to say I hope you had a good lunch. I know I really enjoyed it, and I managed to get it all over my jacket, but that's another story. So I hope you had a good lunch. I hope you have had a chance to stand up and stretch your legs and move your arms around and get the blood flowing. That's an important part of being healthy. If Monique was here, and she may do this later this afternoon, we may ask you to get up and do some stretching and do some activity, but I'll leave that to Monique, I think. As the Olympian, she has more authority than I do, I think. So with that, I'm going to invite our next speaker up. First, I'll introduce her. But the next topic, as you know, is oral health. And so the next speaker is Dr. Herenia Lawrence. And I won't read the whole bio because you have it in front of you. But I do want you to know that Dr. Lawrence is an associate professor of dental public health at the Faculty of Dentistry at the University of Toronto. She has extensive experience as a principal investigator on both intervention and observational epidemiologic studies in the field of Indigenous oral health. She's worked with us in the past. Some of you will be familiar with her work, and I'm very pleased to invite Dr. Lawrence up to share what is a snapshot of a very rich, very long chapter. So thank you, Dr. Lawrence.
Thank you. Thank you very much. So hello, everyone. My name is Herenia Lawrence from the University of Toronto Faculty of Dentistry. And as Jonathan said, I am presenting the RHS findings on First Nations oral health and access to dental care. I would like to begin by paying my respect to the Algonquin people, the traditional custodians of this land where we are meeting today. Oral health is integral to overall health and well-being throughout the 4 phases of life recognized in Aboriginal culture: child, youth, adult, and elder. From breastfeeding of infants, the arrival of the first baby teeth, and the completion of the permanent dentition in adolescence, healthy teeth help in the nourishment of young bodies and the promotion of self-esteem. Later in the life cycle, healthy teeth and gums allow adults and elders to better enjoy life and maintain body, mind, and spirit. Cross-sectional data across all three phases of the RHS conducted since 2002-03 are available to provide a clearer picture of how key indicators of oral health and wellness have changed over the 20-year period. On this slide, you can see the list of oral health indicators among First Nations adults in the RHS Phase 3 and whether they were also included in Phases 1 and 2. For example, the 2015-16 RHS is the first RHS in which data for a self-reported global measure of oral health were included. All of these indicators belong to the physical health domain, vision, ways of seeing, from the RHS cultural framework, represented in yellow within a four-directional model. The next three slides list the oral health and dental care indicators collected as part of the youth and the child surveys. The analysis that I'll be presenting focus mainly on determining trends across the three phases and across the key indicators of oral health. So here's the list of oral health indicators for First Nations youth. And these next two slides cover the key indicators for children. In addition to the RHS, three other national oral health surveys are helping to fill some of the data gaps in our knowledge. These include the Canadian Health Measures Survey, the First Nations Oral Health Survey, and the Inuit Oral Health Survey. The CHMS, which had an oral health component, was a national survey but excluded people living on First Nations reserves or Crown lands. It did, however, include persons claiming Aboriginal heritage who lived off reserve. The First Nations and the Inuit oral health surveys were direct measure surveys and therefore incorporated clinical oral examinations. Comparisons of the RHS 2015-16 findings with those of these nationwide direct clinical measure surveys are also included in this presentation to assess the oral health of First Nations in relation to the general population. Now on to the results for adults. While nearly 2/3 of First Nations adults aged 18 years and older rated the health of their teeth and mouth as good, very good, or excellent, roughly a third, 34%, rated their oral health as fair or poor. To be consistent with the reporting used in the other national oral health surveys I mentioned, the proportions of adults who rated their oral health as fair or poor are presented in the next two slides. So First Nations adults aged 50 to 59 years and those aged 60 and above reported the highest levels of fair or poor oral health. As one might expect, as we age, we are more likely to have problems with our teeth. Just under 32% of young First Nations adults, 20 to 39 years old, 34.8% of those aged 40 to 59, and 37.9% of older adults reported fair or poor oral health. These age-specific proportions are at least 2 times the national average of 15.5%. Between the three phases of the RHS, access to dental care, an important determinant of oral health, has slightly declined for First Nations adults. The proportion of adults who received dental care in the year prior to the survey decreased from 59.2% to 56.5%, where it basically remained. On the other hand, the proportion of seniors aged 65 and over reporting receipt of dental care in the past year increased from 34% in 2002-03 to 43.6% in 2015-16. It's not shown on the slides, but higher proportions of women than men reported receiving dental care for any reason in the year prior to the survey, 64% compared with 49%. About 1 in 3 First Nations adults reported difficulties accessing dental care. The most frequently reported barrier was lack of coverage for service under Health Canada's non-insured health benefits program, the NIHB program, which was reported by 10.4% of adults. However, we are happy to note that the prevalence estimates for all the reported barriers to accessing dental services have noticeably declined, as seen in the brown bars in the figure. Another positive finding was that the perceived need for the most common types of dental treatments, such as fillings and maintenance, has also decreased across the 3 phases of the RHS, as shown on the slide. Approximately 1 in 10 adults, 11%, reported being edentulous, that is, they had lost all their natural teeth. The prevalence of edentulism, complete tooth loss, has not changed since 2008-10 and remains higher than findings in other national oral health surveys. As anticipated, edentulism was highest at 33.8% for seniors aged 60 years and over. Nearly 1 out of 4 adults, 23.6%, reported wearing full or partial dentures, false teeth, bridges, or dental plates to replace missing permanent teeth. Use of dentures has declined since 2008-10, when dentures were worn by 28% of adults. Among the edentulous, 74.7% wore dentures, removable dentures, in 2008-10 as compared with 67.7% in the present RHS. Denture wearing, either fixed or removable, continues to be more common among females than males. Now, on to youth ages 12 to 17. The majority, 81.1% of First Nations youth, rated the health of their teeth and mouth as good, very good, or excellent, while approximately 1 in 5, or 18.9%, rated their oral health as fair or poor. Oh, sorry, I missed the slide. This one here. 18.9% of youth rated their oral health as fair or poor. Based on national comparisons, the prevalence of self-reported fair or poor oral health among adolescents is highest for Inuit, ages 12 to 19, followed by First Nations 12 to 17, and lowest among those aged 12 to 19 in the general population, excluding Aboriginal youth. Almost 3/4, 74.6% of First Nations youth reported obtaining dental care in the year before the most recent survey. This estimate falls behind the 84.5% for non-Aboriginal youth in the general population. Dental care access, defined as receipt of dental care in the year prior to the survey, has declined slightly since Phase 1 among First Nations youth. The decline was from 78.6% to 75.9% and is now down to 74.6%, so not much, it's a slight decline. Compared to the estimates in the youth survey of the 2002-03 RHS, self-reported dental treatment needs have declined for restorative, dental fillings, and preventive care, fluorides, but have increased for regular maintenance and surgery. Self-perceived need for orthodontic treatment among youth was not reported in 2002-03, but has increased when compared to the findings for 2008-10. Overall, 15.8% of youth experienced problems with their teeth or any dental pain in the month prior to the survey. Compared to Inuit youth, First Nations youth have a lower prevalence of dental problems or pain. The prevalence of dental problems or pain is also lower than that reported in the previous phases of the RHS. Conversely, and in comparison with youth in the general population, First Nations youth have a higher prevalence of dental problems or pain. Dental problems or pain were more frequently reported by females and by youth ages 15 to 17. There was a trend towards lower prevalence of dental problems or pain in all sex and age groups for youth in the present RHS when compared to the previous surveys. This is another positive finding. I will now present the key findings for children ages 0 to 11 as reported by parents, caregivers. Overall, 88% of parents or caregivers reported that their child's teeth and mouth were excellent, very good, or good, leaving only 12% who stated that their child's oral health was fair or poor. The prevalence of fair, poor oral health was highest for the 3 to 5-year-old age group at 16.2% when compared to children from the other age groups in the present RHS. Compared with their counterparts in the general population, First Nations children ages 6 to 8 and 9 to 11 have higher prevalence estimates of fair or poor oral health. Children ages 0 to 5 were not included in the Canadian Health Measures Survey, so no comparisons are possible for this age group. Just under 3/4, 71.4% of First Nations children received dental care in the year prior to the 2015-16 survey, which is a positive. However, in the period since 2002-03, oral health care access has increased only 3.3% among children 0 to 11, from 69.1% to 71.4%. Access to dental care increased with the child's age, and was highest for 6 to 8-year-olds, the majority of whom, 85.1%, were reported to have had dental care in the year before the survey. Among children ages 6 to 11, dental care access is highest for those in the general population at 91%. The lack of available dental services in First Nations communities continues to act as a significant barrier to dental care. 1 in 5 3 to 5-year-olds, 21.9%, were reported to have received their most recent dental care from a dental professional situated more than 90 kilometers from the community. At the same time, visiting dental professionals remain responsible for the dental care of 1/3 of First Nations infants aged 0 to 2. Dental treatment needs for children were lowest in 2002-03, with the proportions then increasing in 2008-10, except for orthodontics, but falling again in 2015-16, except for extractions. Yet, in 2015-16, over 1/4 of children, 28.8%, still needed cavities to be filled. Indigenous children ages 0 to 5 are significantly affected by baby bottle tooth decay or early childhood caries. I will refer to it as simply as ECC. Most cases of ECC are treated under general anesthesia at hospitals, often a flight away from remote communities. Long wait times for treatment, along with the flights, result in high costs, but worst of all, the use of general anesthesia for treating ECC has become the norm rather than the exception. The Children's Oral Health Initiative, or COHI, is an ECC prevention program which was motivated in part by the high proportion of Indigenous children needing dental caries treatment under GA before their 6th birthday. COHI is an example of a federally funded community-based preventive dental program that has benefited from data gleaned from the previous phases of the RHS. The prevalence of ECC in baby teeth increased from 10.9% in infants and toddlers ages 0 to 2 to 24.3% in preschoolers ages 3 to 5, as reported by their parents or caregivers. Among infants affected by ECC, 38.4% have been treated for the disease, whereas 3/4 of preschoolers, 75.2%, have received treatment for ECC. When compared to the 2 previous cycles of the RHS, the prevalence of ECC declined for those in the 3 to 5-year-old age cohort from 29.4% in phase 1 to 30.9% in phase 2 and 24.3% in phase 3 of the RHS. Increased prevalence of parental reports of ECC was significantly associated with those mothers who breastfed on average fewer months than mothers of children with no ECC experience. So in other words, breastfeeding longer was protective against ECC. Children who were bottle-fed Kool-Aid and other powdered drinks, fruit juices, tea and herbal mixtures, and soft drinks were 2.2 to 2.6 times as likely as those who were not fed these liquids to have ECC. Among children who were treated for ECC, almost equal proportions received their most recent care from a dental professional stationed in the community, 34.5%, or by a dental professional situated more than 90 kilometers from the community, 32%. For the remainder, dental care was provided by a dental professional situated within 90 kilometers of the community or by a visiting dental professional. So in summary, access to dental care has increased among First Nations children and seniors. The reported barriers to accessing dental services have markedly declined since 2002-03 RHS among First Nations adults. The perceived need for the most common types of dental treatment, such as fillings and maintenance, has also declined among First Nations adults since the first RHS. However, for First Nations youth and children, the decline in treatment needs only started in 2008-10. Among adults and seniors, the prevalence of edentulosum, complete tooth loss, has not fallen since 2008-10 RHS, though the use of dentures has declined since that survey. For youth, there was a lower prevalence of dental problems or pain when compared to the previous phases of the RHS. And then when examined in light of the 2 previous cycles of the RHS, the prevalence of ECC, baby bottle tooth decay, declined mainly for those in the 3 to 5-year-old age cohort. But gaps still remain, and future research should address the social and cultural determinants of oral health, which are fundamental to the First Nations' holistic approach to health and well-being. The oral health determinants found in the survey that are associated with the risk of ECC were child feeding practices and a lack of dental services available in the community. These determinants were the same in 2008-10 as they were in 2015-16. So taken together, these findings point to a number of positive trends that reveal improvements in oral health and in access to care for First Nations living on reserve and in northern communities since 2002-03. The results of the 2015-16 RHS can help inform interventions designed to prevent and treat oral disease in First Nations people and draw attention to particular age groups and needs that require immediate care. We hope that by the next phase, we'll be seeing data that reflect further improvements to oral health and oral health care for all First Nations in Canada. So this brings me to the end of my presentation. I would like to thank the FNIGC for their opportunity and their data analysts for their support. Thank you very much, and I will be happy to answer any of my questions. Thank you. Sorry, I read. Thank you.
Thank you very much, Dr. Lawrence. So do we have some questions on oral health?
Yes.
Over here.
So I was just wondering if it's taken into consideration whether or not the fluoride content in water, so like the recommended 0.5 to 1 milligram per liter, in water? So that's like the recommended from the WHO?
Most reserves don't have fluoridated water. They don't have, it's economically not feasible to fluoridate the water supply.
And I guess, like, wouldn't that be more of a preventative measure that we could think about instead of leading to more costs later down the road? Because it could prevent, like, maybe caries or things like that. So it's just, like, questions I had for myself.
No, certainly. Water fluoridation is a public health measure, but we have a lot of other interventions, behavior and preventive intervention, that most of them use fluoride therapies. That we can use as well. And targeting earlier as opposed to later, since from prenatally onwards, to cover all the life cycle, the life course. Yeah.
Thank you.
I have a kind of a personal passion in regards to dental therapists and the lack of a dental therapy training program in Canada. And you're talking about the lack of people, professionals visiting our communities. We, in northern Saskatchewan, where I come from, I think we have about a 58% vacancy rate and have had that rate for a long time. And have had no success in getting anybody to fund, because the province doesn't use dental therapists anywhere. It's just in First Nations reserves that we use them. Federal government won't fund a training program. So is there something in your report that would show the need for more increased allied healthcare professionals, because you can't get dentists to go north?
Yes. I think it was a major loss to the Indigenous communities, the close-up of the dental therapist school in Saskatoon, right? In 2011, that was a major loss for the oral health care of Indigenous populations in Canada. And I don't think they have any plans to reopen the school. And we are not graduating dental therapists since the closure of the School of Dental Therapy in 2011. And I don't know, is anybody from Health Canada here? No, I don't know. So maybe they have any information about it. So yes, they have. I've been to Nunavut last summer. I was there last summer, and they are having difficulty filling the positions as well. They have currently only 3 dental therapists left there, and they are trying to bring in from the United States now. Yeah. So does that answer your question? Yes.
So if you had College of Dentistries across the country encouraging provinces or provincial governments to fund allied healthcare, oral healthcare programs like they do in New Zealand and Alaska and Australia.
And they have a wider scope of practice too,
Yeah, if they would give a push for that, then maybe you could get provincial governments to consider funding programs.
Yes, if you get the dental community support, certainly, yes. But they tend to be protective yeah, okay. So no, I think they need to kind of, if you don't go up north, you need to find other dental professionals that will do that, right? Yes. Okay.
Okay. On a une autre question ici en français. So I think we may ask for translation again. Il y a beaucoup de personnes ici qui parlent français, mais pas tout le monde. Alors?
Oh, he's coming.
Vous êtes très utile. Concernant ce l'échantillonnage au niveau dentaire, ma question repose sur les aînés. Okay? Eux prennent beaucoup de médicaments à leur âge, surtout chez les aînés. Est-ce qu'il y a un impact au niveau dentaire? Ça, c'est ma première question. Ma deuxième question, c'est les jeunes qui consomment beaucoup de drogue. Je sais qu'au niveau de l'amphétamine, le speed, il y a des conséquences par la suite. Mais est-ce qu'il y a d'autres produits aussi qui font des dommages, à part que l'amphétamine? C'est là ma question. Merci.
Two questions. First on seniors, the second on youth. As for seniors, are there any drugs that are contraindicated for the good health, the maintenance of good health for seniors' teeth? Are there drugs that sort of destroy the teeth or damage the teeth in particular? And on the youth side, we know that drugs, amphetamine, for example, well, very counterindicated for good dental health. Are there other products, drugs that are deleterious to dental health for youth?
I think most medication that elderly people are on cause what's called reduced salivary flow. We call it xerostomia. So they all cause, without the protective effect of the flow of saliva, the buffering effect of saliva. So they are on polypharmacy, and then it's something we need to watch for. If the dentist, the therapist, and the hygienist, they have, more likely to have mouth sores and because of but not one drug in particular. But they all have a side effect of they are diuretics, right? Some of them are so. And for children or youth, it's depends if you have a chronic condition that you require, if you are epileptic, the drug for epilepsy, to control. So this is across all nations and the general population, what I'm saying right now, but not something that will apply to First Nations in particular. Besides, that was not addressed, and I guess is another chapter that talks about medication, right? That was not part of the RHS, at least for my chapter, our chapter. I think, was there another chapter that talked about drug use? Yeah.
That's in the July release. Or no, that's this afternoon. Yeah.
I guess you can do some cross-tabulations and see if there is any particular drug. Yeah.
So let's remember that question, and we can loop back to it as necessary. Are there any other questions for Dr. Lawrence? Oh.
Hi, my name is Barb Hume, and I'm from the Yukon. I have a question, not a question, but, well, maybe it is, about the purpose of having a book like this for government use and particularly for funding, etc. We do have an issue with NIHB. I want to use that other term because it shows how I feel about them. What I don't see is a recommendation going to NIHB to provide the dental services and orthodontal services for our young people. And I'm just having to go through this with my grandson. It costs $8,000 for orthodontists, but and then we have a process in the Yukon. They have a Northern Secretariat where the prior approval goes to Ottawa. And when I talk to the clerk from the orthodontist that flies in from Vancouver to Whitehorse, when I speak to them, they said, good luck trying to get an approval. Because they said in the last 3 years, we've had one person who had been approved. Yeah. So shame on the government. They spend so much money on documents like this, so much money on getting the information, and what do they do with the information after? Some poor child is suffering. This is another way to get around the government, but with the new Jordan's principle, I had to go to through the government of Yukon. The government of Yukon bills NIHB. So guess who pays in the end? NIHB. So, why do we need to do that to get through to this? So I'd like to see if NIHB is a big culprit, and I've spent 40 years, probably about last 5 decades, working on issues at the community level, working with NIHB and INAC. So I know what the shortfalls and the difficulties that we have as we are service providers and trying to help our people get the services that they deserve.
Yes.
So there's a huge shortfall, and it's just, I guess I'm a little bit, not perturbed, but almost, about the seriousness portrayed about orthodontists and for our children. And if we look at our historical background,
Right.
in the 60s, when we've had so many of our people who have been affected by fetal alcohol, so guess what the physical features and characteristics of those children are who never receive orthodontal work.
Yes.
So I just want you to be very strong in stating, facts the way it is and how the government shortfalls our people and continues to do that.
Thank
Thank
you.
you.
Thank you very much for your insight. I would love to answer your question. I think the point, correct me if I'm wrong, Jonathan and FNIHB, is actually this is national data collected by First Nations over a 20-year period. So the next step, the whole purpose of this document is to show at the national level the levels of disease and treatment needs, and you work with that to Health Canada. I think that's the purpose, right? I mean, is to use it as data, as proof of what's going on. Is that the point? I mean, isn't that the whole point? So in a language that they will understand, because the indicators are the same as used in other national surveys. You have side-by-side comparisons with the general Canadian population. So that's it. Okay, thank you very much.
Hi.
Yeah, okay.
We're with Jordan's principal in Atlantic Provinces in Unama'ki. We have never gotten braces ever approved, and our top 2 things were asked when we first started was housing and braces. And to tell a child who's suicidal or has depression and fetal alcohol, I like that, but you can't even diagnose fetal alcohol barely without, well, in our region, without disclosure. And like, we can do so much, and I don't know why Jordan's principal hands are tied, but they said orthodontics is not an unmet need.
Because it doesn't, there's no, the reason Jordan's principal will not fund orthodontics is because there is no comparable provincial or national publicly funded program to provide orthodontics work. Yeah, so they say it's not a gap.
I think those are excellent and absolutely essential points. Did I hear a? No? Okay. I think those are absolutely essential points. And those are messages that have to be carried, of course, to Health Canada and now Indigenous Services. Our contacts don't appear to be in the room at the moment, but we will make sure that is carried forward. So we will make sure that those messages are heard. A report like this is meant to be the ammunition or part of the ammunition that policy people, obviously leadership, use to make those cases. And point extremely well taken. And the Jordan's principle thing is absolutely meant to be on everyone's radar prominently, but I know on the ground it sure doesn't feel like that way.
Okay, thank you.
We have one over here.
It was just related more with her question, I guess, is what is the link? FNIG is a separate entity, right? An organization. And I know that the board consists of representatives from across the country, 10-member organizations. And it just, what is the link between leadership and the advocacy portion of the research that's being done? I think that's probably where where we're seeing the gap, you know, to look at it nationally. If you're looking at this nationally and doing the research nationally, what is the mechanism that you currently have or are using to use that information that we're gathering to advocate for change?
So the Assembly of First Nations does sit on our board, and we do have representatives from the AFN here today. Yeah, we do have people here from the AFN. So that obviously is one of the connections. And then, not to put any of my board members on the spot, but they too are appointed through regional processes. So there's an element of that political and leadership focused approach as well. The FNIGC is just the technical expertise. We produce the material that, as I said, is meant to be the ammunition for others to carry forward. Does anyone have anything more to add on that? Seal.
Hi, Seal Tournier, board member and a director on the board of directors, Saskatchewan rep. I mean, Sharon, I hear your frustration and you know, acknowledge your question. But for anybody who's been in the health field, as you and I both have, I mean, let's go back to the days when we sat on the Joint Task Force for the Future Management of Non-Insured Health Benefits. I mean, it started in 1998. We got an announcement, was it last year? We now have escorts. And what's the other change to non-insured health benefits? It's a ridiculously slow, glacial, if not astronomically frustrating process to have changes made to have gaps addressed. And you know, we're hoping that these kind of reports continue to put pressure and that we arm leadership, because they continue with that process at AFN and FNIHB, or DISC, I guess now, to address that. Oh, yeah, it's escort for expectant mother, and what's the other one that just changed? Non-insured health benefits. Yeah, now we've got $100, I think, for traditional healers or something like that. So those, and they celebrated that. That was a breakthrough. Since the moratorium, no, seriously, I mean, it's hilarious, right? I mean, we laugh because if we don't, we'll cry. But I mean, we at one point had a 5-year moratorium because we were losing ground, we weren't making it, right? So, I mean, that ties to that larger question in terms of what is the federal government actually doing to acknowledge and to address those huge gaps, right? There's a lot of good words out there. I mean, I was just checking because supposedly Minister Bennett's in Saskatchewan about the new, you know, nation-to-nation framework, and we're here talking about, you know, oral hygiene, oral, you know, dental care for children. So that's part of my response, and thank you.
Thank you very much, Seal. So another comment from the chair of FNIGC, Bonnie.
Hi, Sharon. The initiatives that Alberta is taking, and one of the things that I think we all have to be thinking about as we move forward, is developing those indicators to develop an evaluation framework, and we have to do the work. As technicians in Alberta, we work together, and we're working on just that, is working with the chiefs, the leadership, and because we at AFNIGC are mandated by the chiefs. They own the organization, and all the communities own it through their leadership. But we're doing evaluations through research of the policies, and we're really fortunate in Alberta because we have Big Stone that are administering NIHB. So when we have discrepancies of some of the data that we're requesting back from NIHB, we usually go to Big Stone and ask them to drill down the data, and they're capable of doing so, which is really helpful. I believe Akwesasne is the other administrator as well. So really working together with those nations that are doing administration of NIHB and how we can really do better evaluation to really work on policy changes with the non-insured health benefits. I know that in Alberta we worked with Cheryl Barnaby on the arthritis study, and with Dr. Barnaby's study we found that there was a lot of barriers to getting access to the higher costing drugs like the DMARDs and the biologics. And it was simple things like they had to fail a prescription of ibuprofen before they could qualify for the higher costing medication. And who prescribes ibuprofen nowadays? It's over the counter, right? So, but they actually had to prove that they were failing. The other thing, I think Manitoba had done some work with the cancer control. I worked with the lady there, and her name is failing me, but no, it was Keeley, I think. Yeah, and she had found that a lot of the cancer patients were actually failing cancer treatment because the antiemetics weren't covered by non-insured health benefits. So when I looked at the listing, that is now covered. So, and I think it was like $300 a pill for one of the antiemetics. And so our patients were showing up for chemotherapy and really having severe adverse side effects, and the oncologists were discontinuing chemotherapy because they thought they were having, adverse reactions. But in fact, they weren't coming prepped with the PrEP medication. So you see those changes, but it takes those deeper studies to really find the detail in that data, and that's where changes occur.
Thank you, Bonnie. So if there are no further questions, we're going to move on to the next speaker. I will remind people that everything we're doing in this room is going out on Facebook Live. I've been told that there are many of our Health Canada Indigenous Services colleagues, if not glued to their computer screens, then certainly tuning in. I'm speaking directly to them right now, and pointing out the fact that there is definitely messaging here that needs to be carried to senior leadership within Indigenous Services. So, with that, I'm going to go on to our next speaker, and it's a return engagement. Drew Palainen, am I saying that right, Drew? Palainen. Drew Palainen, sorry, I don't have it in front of me. Topic? Healthcare access, right. Okay, so here we go. Drew, welcome back to the stage. Thank you.
Thanks, John. And I think this topic is particularly timely given some of the discussion that's just happened. I said a few thanks before my first presentation, but I forgot to mention one thing that struck me so far over the past couple of days is how much I've learned, not just from the presenters here, but also everyone in the audience. So thank you to everyone who's gotten up to say something and share your experience. So I'm going to talk about healthcare access. Access to healthcare is one of the pillars of one of many pillars of well-being. Obviously, there are others. People have been presenting on those today. I'm going to talk about three aspects of that in relation to First Nations health and the RHS today. The first is access to medical services, healthcare. The second is access to traditional medicine. And the third is access to preventative care. So first off, how do First Nations adults feel about the quality of care available to them? Well, it may not come as much of a surprise that people in rural communities, earlier I outlined what the definition of that means, but people in rural communities overwhelmingly, and remote communities overwhelmingly feel that the quality of care available to them is not, the question is not asked in relation to others, so this is just, the question is, how would you rate the quality of service available to you? So when I'm comparing them, it's not, the comparison is not made in the question itself, but, and there's a 2015 report that came out from the Office of the Auditor General, so around the same time that the TRCC final was coming out, that looked at the disparity in health services in remote communities, and they came out with a number of recommendations. So this is fairly recent history, But a number of recommendations around, specifically around training for nurses. They found in rural communities, healthcare practitioners were being asked to do things that they weren't necessarily trained to do. So more money for and funding for training. Also more collaboration with those First Nations communities around what their healthcare priorities were, instead of this more top-down prescriptive approach. So that's sort of that, you can see that reflected in here. So I think, I mean, it's still a little bit soon whether to see what will happen with that, but Health Canada did respond in the final report. Health Canada responded and nominally agreed with all of the conclusions and all of the recommendations. So time will tell whether that disparity evens out. I'm going to try and move along a little bit quicker than I did for my last presentation because I think I went a little bit over time. So this is this table here is showing the healthcare experience of First Nations adults. So you can see the most significant number here is that close to 10% of First Nations adults on the RHS Phase 3 had some unmet healthcare need in the previous 12 months, which is a big number, 1 in 10. And we'll look at the barriers. To so this is out of those who did require care, whether or not they received it, the types of barriers that they encountered. So you'll see we've had some discussion of the NIHB. And you definitely see that reflected in some of the top barriers to accessing healthcare for First Nations adults here. The top, I'm going to say roughly the top half of this table, the statistical significance of those differences are not there. So the order is not necessarily statistically significant. So if you kind of look at the top, especially the top 5, as sort of being relatively equal in terms of importance. You see there's 2 NIHB related issues there. One, which we've talked about, is the issue of coverage. The other is the issue of education around knowing what is and isn't covered, regardless of whether it is or not. But then also waiting lists and lack of resources. And this, I may be jumping the gun a little bit before getting to the conclusions, but I think one of the recommendations of the TRCC final report, which is encouraging more training and getting more First Nations people working in healthcare in their communities, is I think a recurring theme that you're going to see over this and the following slides, is that seems, at least from the research I've done and looking at these numbers, that seems to be a huge part of the solution, especially for those remote communities. And linking to what I said earlier about people wanting to work in their communities, there's definitely an opportunity there. This is the healthcare experiences for children. Hearteningly, much lower percentage of children with unmet healthcare needs. There's a few different kinds of reasons for this, but there's definitely literature that shows that people put their children first and are willing to make more sacrifices to ensure that their children get the care and resources they need. So it'd be interesting to do a deeper dive into this and see what's going on behind the scenes here, whether there, what kinds of sacrifices are being made for this. But I mean, on the surface, a positive number. Barriers, again, pretty similar. Lack of resources, NIHB issues in terms of funding and cost of services. This is the frequency of change of healthcare provider. So how often did a healthcare provider change in the past year? Or how often did your healthcare provider change in the past year? Again, remote communities, it's hard to convince healthcare professionals to go to these remote communities in the first place, let alone to stay. It's a tough, a tough place to work. But all the more important that we train, residents of these communities to work in their own communities, and it not be dependent on fly-in doctors as well, as was sort of touched on in the oral care presentation. These charts have to do with types of services being accessed. 3/4 of First Nations adults had visited a doctor or nurse in the last year, which is, a positive number. It shows that people are seeking out care in their communities. Shows that there's, to some degree, an open line of communication there between healthcare professionals and their communities. And one thing I didn't kind of go into detail on, but in terms of primary care providers, a lot of literature talks about the importance of those primary care caregivers as a gateway for different kinds of medical services. But the problem in First Nations communities is that you have a history and a tradition that there's a large degree of mistrust there, well-founded mistrust, and so again, I think that goes back to again one of these solutions of getting more First Nations people working in healthcare. I think that would go a long way. I feel like a broken record with that, but I just can't stress that enough. Access to traditional medicines. So there were some new items on traditional medicines in the RHS Phase 3, which is great. Makes for comparison with the Phase 2 RHS a little bit more difficult. But compared to the Phase 2, the numbers definitely look, the numbers are good. There doesn't seem to be a negative trend. This graph shows the prevalence of consulting a traditional healer by education, which was also done in the RHS Phase 2, although with a slightly different question, and showed a similar result that people with more education are actually more likely to consult traditional healers. Possibly for a couple different reasons, but also there are barriers to accessing traditional medicine. We'll see some of those barriers coming up soon, but a lot of people don't know about either about traditional medicine or what it is or where to access it. So people with more education potentially don't have that same barrier. Also, there can be costs, also non-insured costs that aren't covered by NIHB related to traditional medicine that people with more education and higher incomes are able to overcome. This is the same result, but for youth, it's pretty comparable to the result for adults with less than a high school education. And similar item, but instead of asking about traditional healer, this is in the past 12 months, did you use traditional medicine? So in the RHS Phase 2, the question asked, do you use traditional medicine? Where in the RHS Phase 3, the wording was changed to be a little bit more specific, which I think is a good thing for measuring changes over time. But it did specifically ask, have you used traditional medicine in the last 12 months? But I did bring the percentages just to compare. So in the Phase 2, the number that said yes to that was 40%. But keep in mind that was people just saying that they use traditional medicine in general. And in the Phase 3, 35%, so a little bit lower, but 35% said that they had used it in the last year. So to me, that seems, again, can't compare them directly, but it's definitely a positive sign that that close to two-fifths of adults are using traditional medicines. I didn't really give an introduction to this section, but aside from the use of traditional medicines being an important part of the First Nations determinants of health, an important part related to things that have been talked about today, culture and traditions. Aside from that, there is evidence too that on top of those benefits, that traditional medicines in conjunction with Western medicine can result in better health outcomes. So again, keep in mind, it's not just that cultural side of wellness that we're looking at here. We're talking about traditional medicine as an important piece of physiological wellness as well. So I kind of mentioned this already, but some of the biggest barriers to accessing traditional medicines, and this speaks to the importance of education and passing on knowledge and things that could be done. I think it seems that the top barriers are that people don't know where to access traditional medicine and they don't know what it is. So I think there's definitely room for some education, public education, in terms of traditional medicine and promoting that as part of a complete picture of wellness. And again, that ties into the TRCC final report that called on medical practitioners to embrace and respect traditional healing practices. And I think the type of education that could help solve these top two barriers here are part of that. So finally, we're looking at preventative health care. And just to sort of quickly summarize something I've sort of mentioned already, but preventative health care relies more than a lot of different types of health care on trust between healthcare practitioners and their clients. And I think given the history with Indian hospitals notably, but other history of institutionalized racism in the healthcare industry has led to a situation where trust between healthcare practitioners, especially non-Indigenous healthcare practitioners in First Nations communities and their constituents, has been damaged quite severely. So that's sort of the big picture trend that feeds into a lot of these numbers that you're about to see, which I won't necessarily talk in detail all about because there's a lot of numbers. I should have included as many tables as I did. Again, too many numbers here, but in general, First Nations women are more frequent participants in preventative care, which again is not wholly different from what you would see in the general population as well. There are issues for men. There are issues of masculinity, different kinds of things that there is actually a body of research on around showing weakness, not wanting to get these kinds of tests done. Although one thing that I think would be interesting to looking at further research would be looking at these types of barriers for men accessing preventative care, but from a First Nations perspective, which is, as far as I can tell, not something that has been done. This is the same table, but for First Nations youth. The difference there is that there is the HPV vaccine, which the uptake on that is relatively high, close to 50%. Uptake on the HPV vaccine varies quite widely across the country, from around 50% and upwards. So, I mean, I think that's a success story. Still some work to be done. The idea of boys getting the HPV vaccine is a relatively new phenomenon. So I wouldn't kind of concentrate on that number too much because that's something that's still kind of being ruled out in all spheres. Breast examination and mammograms. Again, I should have summarized this a little bit better, made it easier to digest. But younger First Nations women more likely to have breast examinations than mammograms. And again, if we're comparing these rates to the general population, actually not significantly different. And I think that speaks to women's participation in preventative health measures in general. Pap smear, again, similar story. I think the numbers are on par with government targets and the general population. So going back to kind of what I mentioned earlier about men's health, not something that's been studied in a lot of detail, even in the general population. But the Prostate Cancer Canada recommends some kind of prostate screening begin at age 40. And you can see that only about 20% of First Nations men had undergone some type of screening in their 40s. But not, I dug around a lot and could not find any kind of comparison numbers for the general population. I think that speaks to how much research there still is to do around the particular barriers that men face to participating in screenings such as this. And there may be barriers specific to First Nations men as well that would merit some further research. Here's a little bit more detail on the HPV vaccine. Not significant differences by the significant differences are between boys and girls, not between youth of different ages. All right, and some highlights, which again I've probably been talking about all along, but just to kind of summarize, and I think I'm more or less on time. Quality of care in remote communities. Again, lack of resources, funding, and personnel. And I think the TRCC calls to action around getting more First Nations people into healthcare is a big part of the solution for this. And I think the data overwhelmingly points to that. Lack of health professionals, long wait times, some of the biggest barriers, but also issues around the NIHB. Somewhere around 20% of people who needed healthcare cited that as a barrier. And I'm not in the insurance industry, but if 20% of people are having trouble with your services, I think that sends a clear message that something there is not working, and it seems to be a combination of what is and isn't covered, and the education and messaging around that. Access to traditional medicine. Over a third of First Nations adults had used traditional medicine. That's not a small number. So that's, and I think someone, I forget who, but someone did mention, how prevalent the use of traditional medicine is. And I think I think it's really heartening that that's increasingly being recognized, from, as a start, being recognized within those communities. I think that's an important first step to then ultimately getting that respect from the calls to action from healthcare professionals more generally. Adults with more education using it more. I think, again, that just speaks to education, getting the word out there that this is something that is a viable part of a holistic healthcare system. And again, that lack of knowledge, getting the word out. People will want to use these traditional medicines. They work, but people have to know where to access them and what exactly they are. Preventative care, females doing a pretty good job of participating in the screenings, roughly at the rates that public health practitioners like to see. Low rate of prostate screening among men. Again, this is not a uniquely First Nations problem, but there may be unique First Nations perspectives on it. And finally, HPV vaccination rates. I say here that I feel like I'm contradicting myself a little bit. I think there's still work to do because the government target is more than 85%. Again, though, this is not a uniquely First Nations challenge. I think there's a lot of provinces that have work to do to get their general vaccination rates up to that 85% target. Thank you.
Okay, and do we have questions or comments for Drew?
Hi, Drew. Thanks for your presentation. I'm not sure if it's possible to go back to the slide on preventive healthcare. I don't know if you have the control for that. Okay, that's okay.
They might be able to. I think we might be able to pull it up.
If it's possible, otherwise I'll just make my comments.
Okay.
So my name is Sarah Brockapay-Funnel. I'm a First Nations physician, and I'm a member of the First Nations Data Governance Council with the Chiefs of Ontario. I'm specializing in public health, and so I just had a few comments about your slide on preventive healthcare. So certainly it would appear that breast exams and prostate exams are below what we would want. However, the recommendations for both of those exams have changed. And so I think it's probably worth taking a look at what those questions are in the survey and making them more relevant to what the current recommendations are. So that's what would be my comment. But I entirely agree with you that HPV vaccination rates, we would want to increase those for sure. So that's all my comments. Thanks.
Thanks very much. I do see Drew and my colleagues making notes. Thank you very much for that. Bonnie.
Just a couple things that I think I caught. The one thing that I think we need to look at when we're looking at barriers or self-reporting is if they left without being seen. That wasn't in there, but it's a huge issue when we're pulling administrative data and we're looking at the ED utilization of information. And I know that a lot of us have not wanted to, or we haven't put racism in the survey as a blatant question, but it has to be there. We are, in Alberta, we just received a grant to look at racism in the ED department. Manitoba experienced blatant racism with Brian Sinclair, and that system spent hundreds of thousands of dollars in legal fees to prove that wasn't racism, but it was blatant racism. And Alberta Health Services has just apologized to my people in the Blood Tribe for blatant racism and fired 2 employees for racism. Not even a month and a half after that huge apology and that huge ceremony of really coming together and accepting their apology. Eugene Braverock, who is our movie star from the Blood Tribe, he starred in Superwoman. His mom got kicked out of the regional hospital in January 24th. She was told that her bed needed to go to a taxpayer. So racism is alive and well, and we need to address it. We need to call it what it is, and we need to really understand what people are experiencing. So that is something I think we need to put in the survey.
Do we have others? Yep. Okay, whatever you're comfortable with.
I had a question come from our table, asking the question in terms of access to traditional medicine, and what's really captured in that. Because when we go for healing, anyone who's ever gone for healing, it isn't necessarily about consuming traditional medicine. Like, there's a lot of ceremony that's undertaken or you participate in, and I'm not sure if that's accurately captured in the way that we're asking that. So maybe in the next round we need to try to capture that differently, because I think people are accessing traditional medicine more than the numbers are telling us. So
I know there were, the survey question, there are a few examples provided. I don't remember them all off the top of my head. There, traditional medicine, and then I think it says that it can include traditional herbs, healing ceremonies, and I think there's one other example that's provided. Sorry, I don't know that off the top of my head, but I think that's definitely probably a question, more so than many others, that would benefit from making sure that when we ask it, we're capturing everything we want to know. That's a really good point.
Just as we're talking about traditional medicines and encouraging the use of traditional medicine, that we can remember the principles of OCAP and apply them in that sense. We have this discussion a lot back home about the use of traditional medicines, and then the marketing of traditional medicines, and then the sale of traditional medicines, especially in this era where we do have a new age approach and everybody's kind of got something for sale. Now, there are a few problems with that. One of them being, if you don't know what you're doing and you go out and you're looking for traditional medicine and you kind of grab what looks right, you can die. It's that can and does happen. Also, we have situations as well where people from outside of the community are learning how to harvest, gather, and prepare traditional medicines, and then they're selling them, or they're writing books about them, or they're profiting from them. And we have to, I think, if we're going to ask people to publicly speak to this or to speak to the survey about their use of traditional medicine or their access to traditional medicine, that we ensure that these principles we're talking about here with our information applies very, very strongly to that as well.
Thank you, Christine. Do we have any other questions or comments? Okay.
Sorry. And it's not even related to this. Well, it kind of is, but it's not.
That's okay.
But when you started presenting around all of the screening targets or whatever that we were looking at, it kind of triggered me in the need maybe for adding screening targets for dental, and whether or not people our kids are getting caps, whether or not they're getting fluoride, whether or not they're getting silver nitrate treatments, and like all of these other factors potentially. You know, if we ask all these related screening questions related to other prostate health, breast, pap, whatever, that, and we know that dental is a big issue in our communities. Like, for example, I know that silver nitrate, for example, has been proven to be a good preventative measure in dental issues, but FNIGC, Health Canada, has to do more research on it, whether or not it's going to be added to the formulary to help our kids with these preventative measures or whatever. But those are just my other comments. Thanks.
Thank you.
Thank you.
Last chance for Drew. Okay, one more.
Hi, my name's Tina Kitch-Kizik. I'm from Chinupokpa in Manitoba. I guess one of the things, well, my main question would be with transportation on our communities. We have medical vans. There has never been an increase. I know you guys have been talking about talking with FNIB, so maybe that's one thing we can discuss too. Because we're at, what, 20 cents for private vehicle rate from our community to Winnipeg or Brandon or wherever, and that's not very much. and we get funded for medical vans depending on your population. So for us, we're a small community. We only have 2 medical vans, and we have a population of about 200 to 300 people on reserve.
I think that's a great point. The transportation definitely, I forget where exactly shows up, but it's definitely definitely in those barriers that people cite when it comes to accessing healthcare services. One thing that could be done perhaps that I didn't have time to do, but I would be looking at those barriers over time and seeing if there have been changes, whether certain barriers are becoming more significant than others.
Okay, Bonnie is exercising her chair's prerogative and making one more comment.
Just a comment on the medical transportation. In Alberta, when we did research on cancer pathways for our cancer survivors, we found medical transportation to be one of the biggest barriers to services because there is no way of safe transportation to and from the clinic because they're immunocompromised. So after treatment, they're being asked to get into a van with sick people and riding up to 14 hours to go home, and they're severely immunocompromised. So there is no safe way of transportation through the current medical transportation system.
Thanks for that perspective. It may be, as you point out, it may be a barrier that where looking at its significance on the aggregate doesn't tell the whole story. Maybe it's something that is more regionally or even specific to certain types of ailments. So thanks.
And thank you, everyone, and thank you, Drew.
Thank you.
So we do have another presentation before a coffee break. And up next, we have Jeff DeHont, who's going to be talking about mental health and substance abuse. And I'm going to introduce Jeff, another creative theater person. So I've got a couple here. Christine, I know, mentioned that yesterday. So Jeff is a member of the Lenape Nation at the Six Nations of the Grand River. He has over 2 decades of experience working in mental health and substance abuse treatment services as a clinician, a program manager, and policy analyst, gained through positions in the Ministry of Health and Long-Term Care, the Center for Addiction and Mental Health, and homeless shelters, particularly Native men's residences. He has a master's degree in social work, and his work, as I said, was focused on creative interventions. So I welcome Jeff to give the overview of his chapter.
Thank you all, appreciate that. So stories are my life. You heard a bit about theater, but social work is also a story. It's, I hear hopeful and painful stories as a social worker every day, every minute. I also write hopeful and sometimes painful stories as a writer, and there's a reason for that. They're related. It's sort of my way of coping with what I hear. Data also tells a powerful statistical and sometimes visual story. So we're in fact dealing with Stories Day, and I know we're in the middle of the afternoon, as things are starting to drag a bit, just because there's so much information coming, hitting us and connecting us. Let's remember what we're actually talking about. Real people told real stories to generate these numbers and these visuals. And I want to honor that right now. Real people sat down and took time away from their families, including yourselves, to honor these stories. So we are honoring something very powerful, a very visual and statistical story, but a story nevertheless. These might not be the same stories I would tell around a fire to my grandfather, but they're still powerful, and they come from those stories that might come from those areas. So let's just remember that. I'm also not used to speaking in data. I'll just call it a language. I'm going to say this out loud. So honestly, I studied stats in 2004. I've used them to help perfect my work, but I am not a statistician. I'm not a data person. So I might struggle a bit with the presentation just because it's not my usual language. So my apologies to those that do study this, do honor it, and do carry this language properly. If I goof up, I goof up. And you'll correct me, and that's cool, and we're good. But I just wanted you to know that ahead of time. So I'm out of my element here. I write plays, I do social work, man, but I will do my best, okay? Just gonna tell you the truth. Okay, so thank you in advance, though, for letting me tell a story very close to my heart. I will just say this before we get into the presentation. Mental health and addictions have touched everyone I love. Everyone. They've touched me indirectly. This is not that we've either had these issues or we've loved someone that's had them, so or caring for someone that's had them. So I'm sure that's a story for most of us in this room. So I'm just saying that because this is a huge story that affects probably everyone in the room and everyone we love. So I just wanted to note that before we dive right in. But let's go. So if you're familiar with the First Nations Mental Wellness Continuum Framework and the recommendations from the TRC, you'll recognize where I'm going with this, okay? I'm not reinventing the wheel. Those were strong recommendations. They were very powerful. It's a very powerful framework. This work builds on that. And I want to keep a strength focus in mind as we move on, because this topic can get very colonial in a hurry. I will just say this. The data can drive us away from the First Nations conceptions of health and into the oppressor's conception of health. I will just say it out loud. So let's remember that. So you're not going to see me, Jeff, speaking as I would if I was on my home community or if I was in your communities, okay? We're talking a different language here, but just keep that in mind. We're smart people, we can do this. So I just want to keep it in mind. So we want to consider the impact of residential schools, all that stuff. We've heard about this before, I won't go into it. We've heard some very powerful presentations of these topics before. Always keep this in mind. Even if the language you're using isn't telling this story, that story's always there. Also, the narrative of trauma. Even if I'm not using the word trauma, that narrative is also there, okay? So that gives us a lot of context for these stats we're gonna hear. So if we hear a stat that's like really disturbing, there's a context for it, okay? I just wanna make that clear. And also, let's remember that we're communities of balance. So sometimes we're talking about pain, hope is still in there, okay? Never forget that. That balance is crucial. All right. So there's a lot of, I was hoping to do a lot more comparison between the general population and First Nations, but then I realized that's probably not a way to go because of the cultural differences between the language we're using. So some of the slides, following slides, use deficit-focused language, for example. So many of our communities wouldn't use that language at all. So that becomes hard to compare sometimes. And also we have to remember the First Nations and the emphasis on physical wellness, spiritual wellness, et cetera, all that very powerful, important medicine that also needs to be brought in. So if we're talking about mental wellness, we're in fact talking about wellness in all of those. There's some things let's focus specifically on mental wellness as a Western concept, but we just have to remember the whole story isn't being told in these slides, but it's still told because we carry it. Okay, our hearts tell a story. Our breath tells a story. The fact we're in a room together tells a story. And then Western biomedical models commonly characterize mental wellness as the absence of mental illness. We all know this is more sophisticated than that, so just keep that in mind. Okay, so this chapter was divided into 3 sections, adults, children, and youth. So we'll start with adults. And their self-perceived mental wellness. So in this phase of the data, half of First Nations adults said they had excellent mental health. And let's go on. Here, give a couple, sorry about that. Went too fast. But if you factor in good and mental, or very good as well, we get up to almost 87% of people actually self-rate their mental health as good, very good, or excellent. Is anyone's jaw dropped to the floor? I did. I'm just going to say it out loud. Racist stereotypes, I would have said the other way. I would have said it'd be 13% and 87% of people are struggling. Okay? So I just want to highlight that. This is what people actually said. 24,000 people self-rated their mental health, and this is what we got. So there aren't a broad range of diagnoses in the tool, and there's some good and bad about that. So this is what we had to work with. You can sort of see the actual results. I'm not going to dive too deeply into the people that reported being diagnosed by a professional with these particular issues, but you can see it's around usually 1 in 10 for anxiety and mood disorders, and then a little lower for ADD and ADHD, and also the spectrum, the autism. So that is what it is. That's what we had to work with in terms of people self-reporting their diagnoses by a professional. The survey did include some discussion of its distress. So there's the Kessler Psychological Distress Scale. It's distress scale, sorry. It is included in the survey itself. 10 specific questions. 2/3 of adults, based on these results, were likely to be well. And on the same results, we had nearly 2 in 10 might have severe to, moderate to severe mental distress. And when we compared this to more cultural notions, nearly, almost 7 in 10 folks reported strong physical, emotional, mental, and spiritual balance almost most of the time. So, again, these results show the majority of First Nations adults perceive their mental health as strong, but a minority experience significant distress. So, and this is just the graphical, the chart sort of detailing the results. I won't go through this in detail because it's late in the day, but this is available for you so you can have a look at it later, but you get the idea. So we go everything from look likely to be well, and we also have a look at the balance factor that I just mentioned. Another part of mental health where I come from, and is maybe similar to your communities, is that mental wellness we defined about connecting with others. So I had a look at that actually. How many times did someone discuss their emotional or mental health with others? And you can sort of see there's a scale along the bottom here. I'll make it really simple. So the most significant ones are obviously on the far left because we put the most common down to the least common. The most significant, to no one's surprise, would be family and friends. Okay? So the people closest to us that carry our blood, share our history, are the folks that most often get approached. The others are professionals. Elders was a little low. I was surprised by that. I thought that might be a bit higher because I know some communities that relationships there. But again, there could be variations regionally on that. When you aggregate the data, that might drive it down a bit. But basically, friends and family are who folks talk to about mental health and emotional issues. Now, in terms of actual substance use, tobacco use is one thing that came up in the survey. So it's a little over half of folks are smoking, commercial tobacco specifically. 4 in 10 are smoking daily, and 1 in 10 are smoking occasionally. And this is a slight change from last time around. It is a little lower. No gender differences were observed, and now jumping ahead, we took a look at how people are sort of quitting when they decide that they do want to quit. I won't go through all of this. So these are folks who identified as current and ex-smokers in the 12 months in the previous 12 months as part of Phase 3. You just get an idea of some of the things that people are attempting to do. So how many times they quit, the various things they use to quit. This is in the report, so you can have a careful look at it. Nothing really jumped out as one kind of like dominant way to quit, except like cold turkey came out a little more. And there could be some things related to other issues we'll talk about in a second. There may be a reason folks are relying on themselves or other aspects rather than going to the medical system. Alcohol consumption. So this is interesting. 4 out of 10 adults reported they had not had any kind of alcohol in the past 12 months, like 0. And they also asked for how often they engage in binge drinking. There's a definition of binge drinking there. So for guys, it was 5 alcoholic beverages in a single setting. And for women, it used to be 5 in previous phases, but in this phase, it was lowered to 4 for this phase. So there's going to be some different numbers because of it. And now you can see this is the frequency of use. As you can see, it's actually quite high. Like a lot of folks had never had alcohol, and then. If you go down, you can just follow the chart there, and a lot of folks hadn't really been using alcohol or binging that much. So, same question was asked about various kinds of drugs. I'm not going to go through the detail, but again, a lot of non-use, basically. And when you look at abstinence rates, this one was stunning. Usually it's 98% of people that were self-reporting abstinence rates for drug use. This is, again, self-reports. So that was quite high. Now we'll take a look at youth. In terms of their self-perceived foot wellness, it's very similar to adults. So almost 9 in 10 people had good, very good, or excellent mental health in this phase. You can see the comparison here between phases. So there has been some shift, but it's relatively close. So a lot of youth are reporting good mental health, self-reporting. Now, again, the same sort of stats from before with the addition of FASD for youth in terms of this. So again, these were youth reporting that they'd been diagnosed by a professional. You can sort of see it. It's kind of consistent with the adult numbers. So it was a little higher for anxiety and mood disorders, not necessarily that high, and a little lower for ADHD, ASD, and in this case, FASD as well. Now, in terms of the distress, they did the same Kessler scale. So again, similar to adults, about 2/3 of folks were experiencing really strong mental health. About 2.5 out of 10 had moderate to severe mental distress. Same numbers relatively to adults for balance. And again, they are likely to perceive their mental health as strong, although a minority experience significant distress. So similar to adults. And again, the same kind of breakdown. And again, asking them, because of the communal nature of mental wellness, who they're talking to, it was very similar to adults as well, so family and friends essentially with lower uptake of professionals and elders. And again, the same asterisks would apply to the elders, that again, there might be regional variations that sort of get lost in the aggregate data. Now in terms of tobacco for youth, there was a change. So the percentage of daily smokers actually decreased from the last phase down to 6.8. So, and you can sort of see they actually, so 20% of last time around first issues with daily smokers, and now it's down to 12. So there's actually a lot of youth not taking up smoking. Okay, let's cut that some more. Let's skip ahead. So in terms of alcohol consumption, a very high absence rate. So basically 3 out of 4 people are not consuming alcohol, again based on self-reports. And this was higher than phase 2. So last time it was 3/5, now it's 3 out of 4. And the proportion of first-age youth who consumed an alcoholic drink in the last year but never engaged in binge drinking also declined, as you can see. So it's a little lower from last time. Now that could also be explained partly because it did change the definition of binge drinking, but it is lower. This graphical representation of what came from before, looking at drug use now. We can also see here absence rates were similar, so in some cases almost 100% from a lot of drugs, but we could say around 98, similar to adults. Cannabis is different, so although fewer people were smoking cannabis, using cannabis this time around, there is around 73% of folks who are actually using it, which is different than the other drugs in here. So that we had a lot of prescription drug use tracked and stuff like that. But I couldn't use some of it because a lot of the results were suppressed due to small sample size or high sampling of variability. So that's why I don't have a breakdown of the drugs for you. We had data specific to cannabis, but we can say the data that was there was indicating a lot of folks were abstinent from drug use. So there's an idea. And children. All right, so strong mental health is apparent here too. So less than 1% of kids were diagnosed with anxiety, depression disorders, similar to data from last time. There was a slight shrink, not necessarily statistically significant, but a shrink from ADHD from phase 2 to phase 3. And autism spectrum also was about the same. And FASD, now it's not necessarily a mental health issue, it's a neurodevelopmental issue, but it's included here because it's a consequence of substance abuse. And it's basically from phase 3 down to now, the numbers are shrunk. So it's about 1/3 of what it once was. And you can just sort of see the breakdown again. Now, with children, there is the issue of maternal substance abuse. So this would be alcohol and tobacco, et cetera, mainly tobacco in this particular case. You'll notice on the far right, there's actually some goodwill stories here, some positive findings. I'll let you go through that, but some very specific cases, maternal exposure in utero exposure to tobacco is going down. I guess the message about smoking is reaching people, and a lot of people aren't smoking. A lot fewer people are smoking during pregnancy, so some good news here. Now, 9 out of 10 women did not drink any alcohol while they were pregnant. It's comparable to, it's hard to make a comparison because we didn't see other data on it. But again, it's very low, and there were some issues of sampling variability, so I have to be careful here, but the report we do have is 9 in 10 First Nation mothers did not drink during pregnancy. So I want to stop here because there's some interesting things that come from these examples. So there are, in the mental health world, a broad range of diagnoses for children and adults that aren't included here. So for adults, you hear about schizophrenia. For kids, say conduct disorders or things like that. They're not in the survey. So if they were included, that might shift things, but we don't know. But it's just something to keep in mind. Also, some folks might answer because it's differently than their actual experience because of stigma. So if you're worried about being judged for drinking during pregnancy, or you're worried about being labeled with a mental health issue, you might not report it. Some folks might not know they have it, particularly with anxiety and depression. If you've never been educated about what it is and what it feels like, you might take that as the norm. Oh, I'm fine. I'm like everyone else. But if you haven't been exposed to the teachings behind it, both spiritual and medical, then you might not know you have it, so you might not, and that might apply to other mental health issues too. There also may be folks there might not be enough folks in the community to notice it, like be medical professionals or elders or whatnot. So these things may be higher, but we're just not seeing them because folks don't know that it's there. It also it relies on adults, youth, and parents to be reported diagnosis by a professional, and I just talked about this. If that professional is not there, then the diagnosis isn't there. So as you can see, most people are reporting really strong mental health, and these findings contradict colonial narratives. I'll just say it out loud. This is not what you read in the Globe and Mail. Not at all, not even close. And if you look at health literature and also go to many communities themselves, they might report a different reality. So let's just also say this out loud. Indigenous researchers themselves in specific communities might not report the same thing. But that said, stronger culturally informed data could explain why, in this case, we're getting high ratings of self-reported mental health, and why broader health literature, news, communities themselves might report something very different. So we need to have better data that can explain what's going on here. Now, a couple of other things to keep in mind too. Phase 3 survey data didn't really explore the incidence of trauma when in utero. So while moms are carrying babies, if there was a threat of child welfare going to the ER or whatnot, we don't really survey about what happens. Did that happen? Did you feel stressed? Did it have a lingering impact? Because that, of course, can also affect the child. And we sort of need to do more research on that too, because that's another area that's getting explored more recently, so we have to have a look at that. We know too little about mental health in this context, partly because of the spectrum stuff we talked about, so PTSD, schizophrenia, internet trauma, et cetera, aren't necessarily part of the survey. And also, we don't know a lot about people's experiences during treatments based on these data. But that said, though, enhanced governance so that we can actually get at these questions properly and control the data and analyze it properly according to cultural standards could also be a huge help. That was in the TRC and whatnot. And also keeping in mind that we're looking at more than deficits in illness. We have to sort of look at the strengths that come with this too. So get away from deficit-focused language and get into language that focuses on the well-being as a whole. And then I talked about the framework, et cetera. And here's some examples of but remember that we're talking about something bigger than what's able to be presented here. So this particular chapter had to cover children, youth, adults, had to cover a broad concept of mental health and addictions. Things like opioid addiction aren't in here specifically, suicide aren't in here specifically. One of the reasons they aren't is because those are very powerful, cutting narratives that really touch people to the heart. With this amount of space, cutting that story down to a slide or two is devastating. Just absolutely devastating. But I do want to acknowledge that that is there, okay? So I'm not unaware of these things. This is why we need strong, focused, culturally-based research, because when we do this, we can provide those supports and do the report properly and analyze it from a multivariate number of perspectives. So that's also very key. So that information isn't here, but I am aware why. And I just want you folks to know that, because this is a very powerful, cutting story. And the worst thing you do is tell it piecemeal. because that means it's not told properly and it has a major impact. So just wanted to highlight that. Okay, so thank you. Appreciate your time.
Thank you, Jeff. And we're going to open it up to questions and comments. I know we have a couple in the room already, but we do have a question coming off of the Facebook Live, and it's from Christine Abel, who asks, or who says, "Hi, Jeff," and then asks, "Have there been any discussions on how these statistics speak to the high prevalence of suicide in First Nations communities?"
So these specifics, I mean, just to touch on that a bit. And hi, Christine, back. I used to work with her, so. So in terms here, so this analysis does not include that for the reason I just said. But that said, yes, there are lots of broader discussions connecting sort of mental wellness, mental health to the issue of suicide as a whole. It is something that we need to look at very carefully, specifically as a topic, highlighting it in this flat out. So a lot of information isn't included in this particular report. As I said earlier, it is a major issue. It requires a lot of intervention, and it's something hopefully we can do very specific things in. I would encourage action research as opposed to just studying it, so we can actually intervene, and then, I think if you're not so good, but to actually intervene in the issue, and then study the effects of the intervention rather than waiting and seeing what the ideal intervention is. A lot of folks already have a good idea, but in terms of the specific question being asked here, in this specific report, no, because it's too big a topic. It requires a thorough examination, and this would have been a cursory examination, and it needs to be honored, so.
And just further to that, so there is one chapter that isn't being presented here today because the writer couldn't be here, but in volume 2, the chapter on personal and community wellness really looks at suicide in relation to personal and community wellness. So when volume 2 comes out, just keep an eye out for that.
Hi, Jeff. I'm really concerned about having our youth saying that they're in balance or that, things are well with them. Because when we were implementing the RHS 3 in our communities, there were communities that we couldn't even go into because of, and I'm glad Kyla said this, is that the high suicide rates. We had the same problem when we did the REES in our communities. We had a workshop at our health forum, and we got sort of really hard questions and saying that no way is our youth in balance, or they're taking care of themselves. So I think that maybe there may be a situation where either the survey's too long and they get to a portion where they just say, I just got to answer this, or we have to word the question a little bit differently. Because if you look at that, that would mean that we're doing really well in our communities, which would be great, but at the same time, that could also harm us in not getting the right programming into our youth in our communities. Thank you.
Thank you. So that's a very key point, and that's one of the reasons that, I'm glad there's also further information coming forward on it. So there's a couple of things in there that I just want to re-highlight. So I'm basically just saying what you said, because I agree with you. You spoke so well, so thank you for that. But one thing to highlight is that specific people might not have been surveyed because they were in crisis. Okay, so that's key. So their information's not here. Okay, so that's something to keep in mind. Also do want to keep in mind that sometimes as things get aggregated, specific communities get lost. So that someone might actually have a very different reality than what's here. Since this is aggregate data, sometimes very powerful stories get muted a bit. So that could also totally be a factor. And you mentioned might be a long survey, so you used to start saying like C, or whatever the case may be. So that could also be a factor in here. I also mentioned stigma earlier in my own analysis. So some folks might go, if I tell you I got a problem, then you're going to come back to me tomorrow and give me a hard time. So I'm just going to say I'm cool. Right? So that's also a factor, because you're answering some of these things might actually have implications for the respondent later. So they might not actually answer as openly as they might. So just acknowledging all of that. These are very valid. So thank you for the point. Much appreciated.
Thank you, Jeff. Another question or comment?
Hi, I have a background in psychology, so I've tried to understand how these oppressed groups across the globe are understood, are constructed in research. And you talked about racist stereotypes at the beginning, the communities, how their well-being, at what level or so. So this language of trauma, do you think, does it do a justice to the people? So research constructs these First Nations people or Kurdish people in Turkey across the globe. There are many communities like vulnerable passive subjects that they construct and they try to send messages to those communities. So my question is, like, what language could we use to make sure that we empower people, like oppressed groups, like rather than constructing them as vulnerable passive subjects, like more like active, resisting, hopeful, participating, mentally well and physically well people. Is that possible given your counterintuitive presentation?
So in terms of this actual survey tool, this is where it gets tricky because communities may have very differences in the language they might consider empowering. And it also requires a heavy amount of connection with the community to say, well, what is empowering? What is the language of strength? Can we use a word like trauma? That's like, if you look at it from one perspective, you may have to go to every community and ask them, and obviously with a survey tool like this, isn't necessarily possible. So I can't answer the specifics of your question. Theoretically, yes, every community would have some kind of language they could use and develop to describe their experiences with empowerment, resilience, or whatever else is appropriate. In terms of developing a survey instrument to get at that, we might not get there, but it could also be that as people are trained to provide the tool, they can also say, like, okay, this is what the tool is saying, but I know down here we might say like, whatever, which is very similar to this. So it could be explained in those possibly in that capacity, but in terms of the specific language, more needs to be known. I would need people that want to be empowered beside me, talking to them, because by definition, I'm a microphone, they're the voice. So I would want their voice to determine what they want to be called.
Thank you, Jeff. Helen.
I just want to make a few comments. So I think what you presented is very much a white man view of mental health, and very much a clinical definition, which is not the definition or how First Nations people would see mental well-being. And I think the Kessler scale was not a good tool to measure mental well-being. So I think we have a lot of work to do in that area. And I also think that a lot of the less desirable behaviors that we sometimes see in people are a response to what happened in their lives and to trauma. So especially these, because what I find is that we so much run the risk to labeling people that there's something wrong with them, but I feel there's something wrong with the environment, with how they have been treated, with the whole history of colonialism. All these pieces make that they kind of act out in the way we see in the stats. And I think that is very important to show that in an analysis, that it's not that there's something wrong with you as a person, but there's something wrong with society. And I think also that sometimes there's a fear for people who suffer from sadness and depression, that if they will talk about it, that maybe something might happen with their families, that their children might be taken away, or that there might be consequences. So it is a very sensitive topic, but very important. But again, we need to all look at it in a broader view of mental well-being or emotional.
Thank you very much, Helen.
Can I just comment a quick comment? So just, I mean, it's exactly, that's what I meant actually. The psychological language sometimes psychologizes things. And when we do psychologization, we start thinking that there is something wrong within the person, and that kind of methodological individualism harms more and more. So that's why talking about colonialism, assimilation, distal factors predicting mental health is much more important and significant than using a language that psychologizes everything and locks everything inner mechanisms of the person, the people. So that just captures actually what I wanted to say. Thank you.
Thank you. Do we have one more? Okay. Encore en français? Pas de problème?
au niveau chez les Autochtones en toxicomanie, c'est sûr que c'est une inquiétude que vivent surtout chez les jeunes, dans les cas de suicide. C'est pas mal plus élevé que je le pense, autrement dit. Puis c'est sûr que quand on parle de suicide, là, on parle des jeunes d'adolescents jusqu'à, mettons, 25 ans. Moi, j'ai eu un fils qui s'est suicidé il n'y a pas longtemps, ça fait 7 mois de ça. Fait que, donc, il y avait un problème de consommation. Puis il y avait une autre adolescente aussi en 2010 qui avait déjà préparé son suicide. Puis quand je regarde tout ça au niveau des... Puis il y en a d'autres aussi dans la communauté voisine.
This is going to be a rather sorrowful story here. It deals with suicide mostly, and youth and addictions. And I think that addiction plays a much more heavy role or larger determination in suicide than one might think, particularly among our youth. When I say our youth, I mean very young teens or adolescents up to about 25 years of age in particular. It's a situation that has occurred in my community. I lost a son about 6 months ago to suicide, and he has a friend who is preparing the same result for himself, and it's a concern in a number of other neighboring communities as well.
L'autre question, c'est sûr qu'on prône pour l'intervention par d'autres services au niveau de la santé mentale. Par contre, quand un de nos membres suit un psychologue, souvent, entre le psychologue et le jeune, ils n'ont pas la même compréhension. Fait que c'est ça la différence qui fait la suite des choses. Donc, c'est ce que je retiens tout le temps quand on parle de suicide, puis au niveau des problèmes de la consommation.
Very often when the problems arise, we have a young person that might be under treatment with a psychologist or a psychotherapist of some sort. And, well, the situation often will still result in suicide because there is a sort of a communications barrier of some sort. There's an incomprehension between the two. They're not necessarily talking the same language. They're not on the same frequency, a misunderstanding. And this seems to be problematic in cases of suicide. We just don't seem to get the signal or the message across. It's a constant issue, and it's a serious problem, and we are seriously looking for more solution.
Thank
you very much for the witnessing.
So I just wanted, the last 4 or 5 comments were very powerful, and I just wanted to acknowledge those. These are major issues, and if a healer is using a different language than someone seeking healing, we're going to run into issues. If you follow Western biomedicine, brains are wired differently. So if you hear certain concepts and you hear certain words, you get shaped by them. So if that shape doesn't apply to your community, treatment can become isolating. I'm just going to say it out loud. Psychotherapy can be isolating. Okay? So that has to be taken into account. I'm not saying we don't use psychotherapy, it's just that we take very, very careful look at the language, and some folks alluded to that, and we take very careful look at the other things that people need in their life. It's not about treatment necessarily, it's not about language necessarily, it's about a life. What's missing from this discussion of mental health today that we haven't mentioned at all is that really this is about life. If someone feels they have a powerful life, they feel they have meaning and they have hope. This comes from the First Nations Wellness Continuum. So that stuff, a purpose, meaning, connection, all that is vital, and that didn't get mentioned here. So whatever language you're going to use, whatever treatment methodology we're going to use, whatever problem, however we're going to solve a problem, that's what we need to be looking at. We don't need to focus so much on deficit language, because that's just going to show like, oh, here's the gap and here's the people sliding through it, and we already know what's happening. We see that right now. We need to look at that. Let's look at the exciting thing behind that gap. Let's look at the ties that can bridge that gap. Let's look at the power we all carry. We're here together now. Let's make sure that that happens for everyone who needs it. And there's lots of different ways to get at that, but I just want to highlight that. So thank you to everyone that spoke very powerfully and very critically. That's extremely necessary. The language is wrong. So I started by saying it. It is completely wrong. It's from another world. And there's always going to be that clash. So let's get down to using the right language. And that's where data can come in. That's where research can come in. That's where tools like this can come in. It points us to the right language. It builds those connections. It identifies problems. It identifies the next step forward, the better step. That's not about psychotherapy and that. It's about the community and the resources that are available to folks, and mental wellness as a continuum. So thank you so much for your time. I really appreciate it. Thank you.
Thank you. Thank you, Jeff.
Thank you again, Jeff. That was a beautiful way to wrap up this session so that we can go into break. The very good news is Juanique is back. And there's coffee. I don't know which one is more important to you, but I'm very happy to see Juanique back. Thank you for your patience and for your participation in the last session, and I look forward to the discussion this afternoon.